So it's my pleasure to introduce Ariel Beery, who is the founder and CEO of MobileODT. He's here to talk about catching cancer using AI-enabled smartphones. A round of applause for him, please.
Thank you very much. Thank you. Hi, everybody. And thank you so much for joining me today and for inviting me. Thank you, Alana, for this wonderful opportunity to share with you a little bit about what we're doing. And my goal for today is to share with you a bit of what is possible using today's technologies. Not so much from the technical side, but more from the structural side. And I'm happy to speak afterwards during the Q&A if you want to go a little bit deeper. But what I would love to speak with you about today specifically is about healthcare. And on a fundamental level, what healthcare requires more than anything else is information. So when I started MobileODT together with my co-founder, David Levitz, one of the things that we were struggling with was we had, on one hand, a technology, which was an understanding that consumer electronic devices were getting so much better thanks to the rise in mobile phones. And we had a need out there. We had identified that cervical cancer, which we'll speak about in a bit, is a leading cause of death for women in rural areas around the world. And it was so easily treatable. But connecting the two was the question that we faced. And what we realized as part of the conversation that we had with some of the world's leading public health organizations around the world was that in the end, on the most fundamental level, healthcare and the provision of good healthcare depends on data. And that's something that all of you and definitely Google knows a lot about. So if I can leave you with two things at the end of this presentation, the first one is that healthcare depends on information, on data. And then the second thing is that mobile computing will make healthcare accessible to every person on the planet. So with those two particular things, I'd love to jump into the presentation, share a little bit about what we do, and then hopefully engage with you in conversation about how you might be able to use your superpowers in terms of your abilities as engineers, as business people, as operations people, to save as many lives as quickly as possible. So I'll step back. My name is Ariel Beery. I have the absolute pleasure to be here today to represent a company called MobileODT, Mobile Optical Detection Technologies. And what we do on the most fundamental level is use the power of mobile phones to address disease. Now, there are a lot of different ways that mobile phones can be used to address disease. Some companies use apps that consumers will use to track their blood sugar or their blood pressure and intervene on a daily basis. What we believe as a company and where we're seeking to contribute is in prevention. So good health care is best suited to preventable diseases, right? If you can catch a disease, almost any disease, while it's early enough to treat, you can clearly and quickly treat it before a person gets too ill. And so you can save years of person's lives and thousands of dollars and families going into debt just by identifying disease early enough. And we believe that the people who are best suited to currently empower with such technologies are healthcare workers. And our mission as a company is to equip healthcare workers, the nurses, the midwives, the technicians, the clinicians that are out there serving the majority of humanity on a daily basis, to equip them with the tools that they need to be able to provide better care. And if we look at that as a mission, then the question becomes, as a company, where can we make the most impact? And so we decided to take dedicated caregivers, to provide them with mobile compute labs, and to help them make an evolutionary jump in their ability to provide healthcare quality, particularly in cervical cancer. So many of you already know this, but I just want to make sure that we're all on the same page. Cervical cancer is a leading cause of death for women in rural areas around the world. It's a cause of death that is, in many ways, the most tragic because it's the most preventable. I'll show you in a little bit how cervical cancer develops, but just on one foot, cervical cancer can take up to 20 years to kill a patient. It comes from an infectious disease, the HPV, the human papilloma virus. And if you catch it within the first 5 years, you can treat it on the spot with basically the equipment you have in the kitchen for less than 28 bucks in less than 20 minutes. So how can it be that a disease that is easier to cure than the flu is killing millions of women a decade? Mothers, pillars of their community. How is that possible? Well, it's actually one of the fascinating things. It's because women aren't screened. So every woman, every single woman of reproductive age should be screened for cervical cancer regularly, whether it be every 3 years or every 5 years, depending on the technologies that we have available. And yet, the majority of women around the world aren't. And all it has to do is that one moment of screening and that one moment of identification of disease in which a woman's life can go from the death column to the life column. Now, what's fascinating is that despite the investment in maternal and child health since 2015, since recently, cervical cancer deaths have become more prevalent than deaths from maternal and child complications. So it's one of those things where just a little bit of investment in regular screening can mean millions of women alive to take care of their families. And that's not a problem just around the world, it's a problem also in America. Almost every person of reproductive age in this room, for sure, and many of the people who will be watching online, will at some point in their life contract the HPV virus. Human papillomavirus is one of the more popular viruses today, and 79 million Americans are living with it at this moment. And what that virus does is it infects the cells. The cells that are infected with high-risk strains of that virus will start to become inflamed, and then they will develop a disease. And if you catch it early, you treat it. And if the body's immune system can flush it out, it'll flush it out, just like we flush out viruses every day. But for some Americans, and for many women around the world, it kills them. Now, the way it works is as follows, and apologies for the graphic images, but I think it's important to recognize because it is a visually accessible disease. So a normal cervix, the cervix, just for everyone who, I learned this when I started at MobileODT, the cervix is where the baby comes out through, right? So it's part of the woman's anatomy. And the cervix, a normal cervix, is fleshy and has squamous cell and columnar cells. As the virus infects those cells, they start to become inflamed. And visibly on the surface of the cervix, you start to see signs that that infection is beginning to grow, right? At that stage, at precancerous stage, you can still just cut out those cells, literally freeze them out or burn them out in a procedure that can take a few minutes using very, very simple technology that can be done anywhere, literally anywhere around the world, and that woman will go from the death column to the life column. But if you let it persist, if that infection continues and those cells invade, then you get cancer. And at that stage, it is almost impossible to save a woman's life. So you have this very long process that can take up to 20 years, where from a normal cervix to a precancerous cervix, you have a 5-year window. And even during that period of precancer, you can still treat easily. Now, what's fascinating is that screening is only part of the problem. So anyone who looks at graphs will generally look at this graph and say, oh, wait a second, the trends are going down. But what I want you to notice is that from around the year 2000 until today, despite the fact that we've introduced tremendous technological leaps in cervical cancer screening, liquid-based cytology, HPV testing, and most importantly, the vaccine, the number of deaths and the number of new cases have basically flatlined, right? They have not gone to zero, which is what you'd imagine, right? All of a sudden, we're vaccinating people, and we're screening with better technologies, and we're intervening when we can. No, we're still seeing thousands of women develop the disease, and thousands of women die from the disease in America. Forget outside of the United States, where those rates are growing every year because infection rates are growing. So the question then becomes, all right, so we have all these wonderful technologies, liquid-based cytology and HPV testing and vaccination, and hopefully everyone listening here is vaccinated. Why is this technology, why are we not yet able to stop such a simply stoppable disease? Well, it has to do with lack of experts. So I like showing the map of the United States as opposed to the map of India or China or Africa because it's so striking. The red is where there are 0 gynecologists. These are counties of the United States of America, one of arguably the most developed and economically successful countries in the world. And that is the map of lack of expertise. So if you catch the disease, where are you going to go? Let me tell you something that's actually fascinating. When I learned it, it blew my mind. 25% of women, 1/4 of women, 1 out of 4 women who were called up and told you have a positive high-grade lesion from your pap smear, you need to come in and get treated, do not return. Half of women who are called up and said, you have a high-grade HPV test, high-risk HPV test, you got to come in for your next appointment, don't come in. And the question is why? Because of distance. And so, and again, this is in America where you have great roads and you have Amtrak and you have buses and you have the ability to get places in theory, right? Forget rural Africa, rural India, rural Southeast Asia. So the problem, the challenge is the connection of the patient and the expert. And that's what we sought to address. So this is the Enhanced Visual Assessment System. This is EVA. EVA is built around the technology that all of us know and love, the Android mobile phone. Right? The amazing thing about the technology that this company, that Google, has contributed so much towards and that we as consumers have supported in its growth is that it's become so powerful in its ability to capture images, process and analyze those images, and communicate with a world of expertise that is on the internet. Right? The things that we know and love from everyday interactions are actually critical to healthcare provision. And what that means is that those nurses, those midwives, those technicians that do see the majority of humanity, by using a device, a medical device, a FDA-cleared, CE-marked medical device that enhances the power of the mobile phone, can now provide expert treatment wherever that woman is. So anywhere that you can take your phone, you can take an EVA system. But obviously, it's not just the mobile phone, and it's not just the device. It's that what EVA does, and devices like it, connected devices like it, is it connects the cloud to the patient at the point of care, and it connects the patient at the point of care and the provider, the healthcare provider at the point of care, to the cloud. And that's what's so powerful about the moment that we're in, and that's why there's such a moment of potential for all of us to contribute. Because once we recognize that, in essence, solving healthcare challenges is solving a data problem, it means that every time that we impact healthcare, we can literally transform the way that healthcare services are provided through connecting dots, through connecting pieces of information. Now, we've learned this, and I'm going to stop the MobileODT segment for a second. We've learned this by working in 29 countries around the world, a lot in the United States, but around the world as well, in the African continent, in areas of the world in which cell phones are relatively new, but thanks to the unbelievable power of mobile devices, basically can be taken anywhere. And what we've learned in all of those countries, whether it be in the most advanced cities in the United States and in India, or whether it be in the most remote areas across the African continent or in Latin America, what we've learned, or rather the question that we've asked though is how can mobile computing really transform healthcare? And what we've learned is that it can do so in 3 different ways. So specifically, what I'm going to posit here today, and the request that I'm going to end up making at the end of this, is that specifically mobile computing can help 3 means of intervention for healthcare. It can help in 1, identifying patients at risk. In our case, because we're still using cervical cancer as our case study here, it can identify women at risk. 2, it can ensure that appropriate treatment is applied. And 3 is that it can ensure adherence. It can make sure that the woman who is told that she's positive is treated correctly and then is followed up with correctly so that cancer doesn't continue to become an issue. So let's go into those 3 quickly. First, Mobile computing can help identify women at risk. This is a scatter plot of data that was analyzed as part of a Kaggle-hosted competition that Genentech, a large pharmaceutical company, made available using Symphony's data set. Symphony is a large data aggregator here in the United States. And what the competition requested was for data science teams to look at this large public data set and identify, based on this large public data set, which women are at risk for cervical cancer. And they found an accuracy of, I think it's over 90% in identifying high-risk women just from public data sets. Now, why is this important? Well, because the United States spends about $6.6 billion every year screening women for cervical cancer. $6.6 billion. 55 million women are screened every year, and yet 10 million women are not. And out of those 55 million women, only 30 million women should actually be screened. So you're basically screening 25 million women who do not need to be screened, and you're not screening 10 million women at highest risk that do need to be screened. And that's why African American and Hispanic women in the United States have rates of cervical cancer that are almost equivalent, and in some places higher, than women in Africa and women in Latin America. Because we're not screening the women that need to be screened, and we're over-screening the women that don't need to be screened. That's just a data issue. It's just a data problem. It's something that could be rather straightforward solved. And once you have that information and you can reallocate resources accordingly and you ensure that the right care is going to the right patients, then you can make the right decisions as to who needs to be taken care of. So that first one is just identifying the women that need to be screened. The second one is applying the appropriate treatment. This is the basic workflow for how cervical cancer screening works in the United States today. And it's the same thing with the Pap smear as well as the HPV test. So let's go through it rather quickly. Woman comes into a doctor's office. She lies on the table. The provider scrapes cells off the cervix, puts it in a little bucket, closes that bucket, gives it to the medical assistant. Medical assistant takes it and brings it into the front corner. They call the logistics company. The logistics company comes in, picks up the buckets, takes them to a lab. Lab then unloads it, brings it to the technician. Technician then takes it, stains it. After they stain it, they then take it and put it under a microscope. They look under the microscope, or they look under as part of an assay to look whether there's presence of HPV DNA. They then identify whether or not that woman has had something that is high risk. They then write that down. That then gets oftentimes faxed back to the provider. The medical assistant takes that fax, looks at the medical record, types in the information into the medical record. If it's positive, then goes and talks to the doctor. The doctor then needs to make a decision, maybe I'll call back that patient. And then the medical assistant calls up the patient. And the patient, 3 weeks later, after she had that test taken, needs to be rescheduled. A little bit complicated, right? So that entire period of time, for those 3 weeks after a patient has come in and gotten a test taken, she doesn't know. And oftentimes, wage workers, rural Americans, single parents have a hard time of scheduling that next follow-up. They just moved mountains to be able to have their annual physical. So they get a call, and they say and the medical assistant says, listen, ma'am, you've gotten a positive Pap smear. And the woman says, all right, I'll call you back when I can reschedule. I'm at work now. And then she has a million things that she needs to do, and she forgets. And that's why out of the $6.6 billion that we spend every year screening women in the United States, $1.2 billion of that are due to non-adherence, to women that are lost to follow-up, because she wasn't able to schedule that next visit in time. And then she comes back the next year, and she's positive again, and she says, oh, God, you told me last year I was positive. And then they need to schedule again. But they don't all come. And so that long process leads to women going from the life column to the death column. Now, what we're doing at MobileODT is what we've found is that you can replace that whole process of collecting the sample, sending it to the lab, and then bringing the woman back for the next step through applying pretty fundamental machine learning algorithms to the images that you capture using a colposcope. So there's some fascinating, groundbreaking work that will be published pretty shortly that I'm not allowed to talk about too much, but I'll try to share the basics of, in which the National Cancer Institute and the National Library of Medicine have done extraordinary work to prove that our partners at Global Good have been able to identify cervical cancer with an accuracy pretty high, a little over 90%, just on a single image alone. And that is extraordinary. Because what that means is that while the woman's in the clinic, without her going through that entire process, in 0.6 seconds, she can go from the death column to the life column. And that's just the beginning, right? Because what's fascinating is that these algorithms, because remember, cervical cancer, just like many other diseases, is visually accessible. These algorithms we already know and love and deploy on an almost everyday basis. Many of you in this room probably write those algorithms. And they're based on Caffe, or on TensorFlow. Now we're moving towards TensorFlow Lite. They're simple, straightforward machine learning problems. Interestingly enough, computer vision didn't really cut it there. But when you build a large enough data set, and currently MobileODT is proud to have one of the largest data sets in the world on cervical cancer, you can use that to identify disease at its earliest stages using nothing more than a visual image. So that has to do with applying appropriate treatment, because if you can apply that treatment on the point of care at that moment when the woman's in the room, you can do so much more for that woman than anything else. But then once you apply that treatment, you need to make sure that she's actually taken care of, right? So the patient examination, which most medical devices do pretty well, is only a very small link in the chain to ensure that patients are kept healthy. Because after that woman is examined, we need to communicate with that woman what it was that was seen and what it is that she needs to do. And if the appropriate treatment isn't there, if it's not for cervical cancer, it could be for any other type of disease, she needs to be referred. And once she's referred, then we need to make sure that we update her record, because if we're not expressing to the other person what it is that you saw, then they might miss it. Because in the end, clinicians are only human, right? And they only know what to look for if they're told what to look for. Again, it's a problem of data. And once that patient record is updated and the provider provides the appropriate treatment, then you want to take that information and you want to warehouse it, because you want to have information about how disease spreads within a population. Remember, cervical cancer is a communicable disease. It comes from the human papilloma virus. And there's so many other diseases like that. If you can find trends, you can know how to allocate resources effectively. And then once you have that data, you can start identifying patients. And then once you identify those patients, you need to examine them. And that continuum is what makes healthcare. And that continuum is a data problem. It's a communication problem. It's a problem that we've solved in social networks, but we haven't yet solved in healthcare. But we can. Now, so for that, there are three things that, to close off the more frontal part of this and to start our conversation, there are three things that I would ask of you, of all of you here and all of you that you know that have those superpowers that you're applying at Google and that you're applying in all of your work outside of it. First is let's help the healthcare system identify patients at risk, right? Let's take public data sets and identify how we can more clearly map vectors and then express that information to healthcare organizations so that they can deploy the proper resources in the most effective and efficient manner so that those healthcare organizations can do what they do best and care for patients. Let's also apply the appropriate treatment. Devices have a huge amount of data exhaust. And obviously, if you have garbage coming in, you have garbage coming out. And that's why for MobileODT, we believe that the critical component is ensuring that you have control over the type of information that comes in so that you can apply the appropriate information that comes out for analysis. So let's connect more devices to the cloud. Do it with all the proper and necessary security precautions to ensure that patient privacy is kept. But you can't identify a woman from her cervix, nor can you identify a man from his oropharyngeal cancer or any person from their skin disease. Let's use that information so that any provider, anywhere, any nurse, any midwife, any technician that can take a mobile phone and bring it into the field, let's make sure that every member of humanity has the same access to the same high-level diagnostic accuracy just by ensuring that they all have access to the right information. And then finally, let's ensure adherence. We've learned so much about social dynamics over the past decade alone. And yet, we're not doing a very good job of ensuring that that woman that gets told that she has high-grade precancer, we're not doing a good job of bringing her back. How is it that we're able to get her to order stuff on online shops, but we're not able to get her to come back to a clinic or get the clinic to her? We understand the social costs of having mothers die in their most important ages. Let's intervene. So figuring out how to do that, that's a data problem. And so the key here is to do the examination, the analysis, and enable the action immediately at the point of care, to do that calculation fast, to do it wherever it is that happens, that the patient is, to bring healthcare to wherever the sick are. And that's where mobile devices are so powerful, because they go wherever we are. And almost every person on the planet now has one. Now, we're doing our part, MobileODT, by taking the same technology that sits at the heart of this device, enabling a mobile phone to be turned into a medical device, and applying it in other diseases that are visually accessible. Anything that you can identify with your eye, that a clinician identifies, from endoscopic procedures to skin, you should be able to do with a mobile device. You just need to tweak it, so using the right optics, the right illumination, the right structures, and so on. But there's so many other ways to do it. And we're hoping that every device company, that every technology provider will start thinking about how they can use their core resources to ensure that their technologies are being used to save lives at the point of care. And just the last thought, once again, is that data is critical, and it's the mobile element that enables that data to be actionable. So all of us here have that native understanding just because we use our phones every day. So let's use them for something that ends up saving a life that might be otherwise lost. Thank you all very much, and I hope that you join us in making healthcare accessible to every person on the planet. And I welcome your questions. So there are two, I was asked to say, there are two microphones. They're illuminated by the spotlights. If you have any question at all, I'd be happy to answer them. And no question is out of bounds.
Hi, thanks a lot for the talk. So I have two questions. The first is, you mentioned the accuracy is around a little bit higher than 90%. Can you talk about maybe the breakdown of that in the sense of, are there false positives or false negatives?
Absolutely. So there are a number of papers that I could refer you to. The seminal paper that will be coming out soon will break it down a lot further. What I can say about it is that what's fascinating about the cervix is that it's a pretty clear example of squamous cell carcinoma, which means that as the cells start to proliferate, they start to show visibility. Now, you will get false negatives, but the sensitivity and specificity are both above 90, which means that you will know that you're seeing something, and you will more or less know that that thing is cancer, right? Now, to compare that to the pap smear to HPV, HPV testing catches a ton of people who have the high-risk strain that will never develop into cancer, because only 5% of the people who have a high-risk strain of HPV actually will end up developing the cancer. And the test just looks for the strain of HPV DNA, right? What a visual examination does is it looks for when the cells are already growing. And that's when you want to nip the bud, right? You want to take away those cells where the infection occurs. And as far as the literature shows now, around 97% of cases, it'll never reinfect.
Thank you. And I guess the second question, this is, so the common, barrier with healthcare is sort of gaining access to data, primarily because of privacy issues. Yeah. Can you, you mentioned that there's a large database that you're probably using to train the algorithm. Can you talk maybe about what has been done in that end? What's the current status in, how are the healthcare providers responding to a need for, technology companies to have access to that data so that we can help them?
Yeah. So first of all, it's a fascinating challenge. I just came. One of the organizational networks that we work with are the Centers for Disease Control, the CDC. And I just came from a conference in Atlanta, the CDC's Informatics Conference. And one of the things that I learned there was that even within the healthcare system, even within the CDC, one organization, they have significant challenges sharing information, right? And it's one of the ironies of the day where we can track almost every human on the planet. We know where they're going and what they're eating and where, what they're doing more or less, but we can't keep them healthy because the information that we get from healthcare providers is all locked up, right? The way we address this is just by building our own database. So every time that somebody uses our system, we have that information. And it's de-identified, and we structure our database in silos. And so any one of those pieces of information, every one of those tables has a different lookup function. And so you can't really get the information about who the patient is with information about what the provider thinks, with the information about who the provider is, with information about what the resulting diagnosis is, right? So you have the ability to structure it so any one of those pieces is de-identified by nature. And what we're hoping is that, and I know that Google is involved in this and a number of other organizations too, what we're hoping is that these standards will start to propagate. That is, every piece of equipment that is somehow digitally connected should enable others to learn from it and to integrate it and to build through its solutions. And I've been very surprised for the good and for the bad about how that works within different healthcare systems. So you have some of the more. So we work in countries where basically there are no landlines. Everything is mobile phones, and there are countries like that some of them are very comfortable with the cloud, and some of them, even though their data center is literally an open shack that sometimes gets rained on, they want things to be hosted locally. But thanks to containerization, you can do that, right? If you build a proper microservices architecture, you can make it work. So I think that we're going to get there, but we just need to get more people to sign on to interoperability standards, and we need to ensure that people recognize that this literally has to do with saving lives, and so delaying is costing lives.
I guess as a follow-up,
Sure.
So what if you are collecting that information? There's always that fear of your data being misused or being identified. So I guess even for me, if I were to go through this, it would be like, all right, like how do I know that this, no one that doesn't need to see this data will not see this data. So on your end, what do you do to protect the data that you're collecting?
Yeah. So first of all, it's what's called secondary use data by nature, because no one other than your provider has the information of who you are and what the examination is. So we cannot be identified by our cervix or by image. Well, it depends on what images of our skin, but you cannot be identified by it. It's just not. There aren't public data sets available to ensure that kind of identification of a person based on one mole. Or on a cervix, or an oral cavity even. And so because of that, the image and the annotation is de-identified by nature. So there's no risk from that perspective that a woman would be identified. But yeah, we need to structure correctly. And so when we structured our database from the very beginning, we made sure that that you literally needed to, you had a salt and hash lookup table between the different tables to make sure that in any which case, you'd have to connect so many different pieces of data in order to re-identify someone, but you just don't give people the keys, so you don't make that available.
Oh, thank you.
Of course, absolutely.
Hi, thanks for the talk. So the question might be out of scope of this talk, but still, do you know of any efforts where machine learning is used to diagnose cancer or other diseases based on other kinds of images like MRI scans or CT scans? Yeah. What are those?
Yeah, absolutely. So first of all, there's now a tremendous amount of information being made publicly available around the world, thanks to national governments and large healthcare systems. So I just heard that the National Institutes of Health just published a huge data set of MRI-based images. I just heard from a friend of mine here that you can all speak with after, that his father-in-law is doing some exceptional work down at Hopkins in identifying cancer in its earliest stages, in colorectal or pancreatic cancer. So there's more and more information becoming available, right? And that's critical. So I think that the real goal has, and this is where I'm going to speak for my thesis. So my thesis is that smart devices are going to make the difference. So data sets are great, but as all of you who are engineers know, data set is only good so far as the source of that data is reproducible. So if the data set, if you have a data set, but the way of collecting the data changes, then the type of analysis that the classifier you built based on the earlier data may not be relevant for future data. And so one of the things that we believe as a company is that tying the data to the device and ensuring that as a full solution, you can control the way you bring data in, the way you annotate that data, and the way you analyze that data, and that becomes a virtuous cycle, then you can really provide care. And so more and more companies are starting to recognize that as well. GE has a huge initiative around it. I know that others also. And I think that as people start thinking about medicine as the application of expertise and devices an extension of the ability to provide medicine, then we'll see more and more of that. So there is skin. I mean, I think Google did a project on the eyes. There is MRI scans, CT scans, and others. And what I find very fascinating is that for the past 20 years, there have been different approaches that mainly use computer vision. But really where the breakthrough has been is in applying really standard off-the-shelf models. And I'll give you an example that might be a little crude but is interesting because it was just fascinating. So it took us a pretty long time to develop an algorithm that can kind of identify the cervix. And then some of you will know that there's a show, an HBO show called Silicon Valley that open sourced or at least gave a walkthrough of how they created an algorithm for hot dog, not hot dog. We took that hot dog, not hot dog instruction, and within 3 days, we built an algorithm that was cervix, not a cervix. In 3 days. It took us like a year to do it before, and then with the new tools that literally just became open, it took 3 days. And that exponential, logarithmic shift in terms of speed and potential is astronomical. It's crazy. Right? And it also makes sense. And this is one of the things that, that's why your superpowers as engineers are so critical here. Because what is fascinating is that you have here a moment in which we knew for all of history, we knew that human beings have the ability to perceive information and to use our brains in order to find patterns in that information and then to make decisions. Right? I mean, that's what medicine is. Medicine is where you have a person who's, a magician, so to speak, a doctor, who goes through many years of school in order to learn all the different things they need to learn. They get to that point of care and they make very educated guesses as to what to look for. Based on what they see, they reference the information that they've learned to make certain decisions. And then based on the decisions they make, the person either lives or dies, right? Well, algorithms can see tens of thousands of more patients than doctors ever could, just because they can literally review tens of thousands more patients. So now we have the ability to actually do what the doctors have done in a way that we simply couldn't before. Yeah.
Hello. Is the anonymized data collected by MobileODT available for people to download, or is that proprietary?
So we do have a data set that we made available through Kaggle in a competition that Intel sponsored on type of cervix, which is critical for treatment. We're going to be making more and more data available to the research community, and we're very excited to work with folks. So please feel free to contact me at any time, and I'd be happy to share information.
And on a similar note, have you thought of using this device as a means to collect data on all other sorts of things?
Absolutely.
Where you can use an image to,
yes.
like the eye or skin?
Yes. So we already have the ability to do endoscopic procedures, oral, skin, absolutely, which is critical, absolutely critical.
Thank you.
Yeah, thank you. Yeah.
Hi.
Hi.
I would just like a little clarity on how exactly the product works. So
Absolutely.
I saw a photo with what looked like an attachment, some sort of scope. But for cervical cancer specifically, are you taking images from the pap smear swab?
No. So I usually don't show it because it's a little more graphic for people who aren't aware. A woman will lie on the table, and something called a speculum is inserted, just like inserted today to take a pap smear or a colposcopy. And our device, which is classified as a colposcope, which is a long-range microscope to look at the cervix, the vagina, and the vulva, is placed at a distance. It never touches the patient. And at a distance, it images the cervix. And based on what it sees and what the provider sees, they make certain decisions. So at this moment, what the providers are doing is using this as a long-range microscope to look at the patient. And based on what they see, they make decisions. And over time, as we start to provide more and more guideline interventions and workflow interventions, it'll also guide them to do more and more. And so one of the things that so for example, we have a wonderful partner in the Rotary Club in San Diego. And they built a partnership between the Jalalabad Hospital in Afghanistan and Scripps Medical Center in San Diego. And the first cervical cancer screening program in Afghanistan was started because EVA systems out in Afghanistan were being used by midwives. And a gynecologist in San Diego was watching what they were doing and providing them with tips on how to actually perform the examination.
Thank you.
Absolute pleasure. Please.
Thanks again for the talk. Have you found cultural barriers in terms of using the actual device? And if so, how do you overcome those? How do you do education so that the women who are receiving care feel comfortable with the idea of a more complex device being used?
Sure. So first of all, we've found amazing universality in certain elements that we had not previously expected. So there are cultural differences in terms of insertion of a speculum. Speculum insertion is problematic in certain places for obvious reasons. Once you get past that hurdle, which has nothing to do with us, then it's pretty straightforward. It's just visualization, and any place in which a speculum is inserted, they're used to a woman visualizing them. What's been fascinating, actually, culturally, is that what we noticed first in Kenya proved to be correct also around the world, which is that women loved seeing an image of their cervix, because women had never seen their cervix. And remember, in emerging markets and rural areas, and in rural areas even in America, cervical cancer is a leading cause of death. So they will know a woman who has died of cervical cancer. So they hear again and again that this is something they should be worried about, but they don't know what it is. And so to be able to turn around and say, this is what I saw, look right here, you have to go and get this treated, was huge. And as part of the interviews, one of the women called it, I saw my cervical selfie, right? They had this moment where it was very empowering for her to see what she looks like on the inside, and in doing so, reduce that fear barrier. So I think that's critical. I think that's critical across all of healthcare. That is, in the end, healthcare has to do with the person, the patient, right? So many times medical device companies think of healthcare in a very abstract form. It has to do with providers and payers and institutions and networks. It has to do about that woman, that one woman. And that one woman needs to own her health, because if she doesn't take care of herself, no matter how much the healthcare system is developed and robust, she'll die.
Cool. Thanks very much.
Oh, absolute pleasure. So we'll take one more question, and then we'll start to wrap up. Yeah.
So my question is more on a marketing standpoint. So who is your target that you're going towards and trying to sell this to? And are you allowed to say how much it costs, or is that something that you're keeping under wraps right now? But just more of a marketing, where are you trying to go to? Is it hospitals or different organizations or stuff like that?
So MobileODT works primarily with healthcare networks and hospital networks. Although obviously the person who uses it is a nurse or a midwife or a gynecologist, their procurement officer is generally the person who purchases it. In the United States, we sell them for $4,800 each for this generation, which is about 20% of the price of a traditional unit. And the goal is for price to never be a barrier, right? We want to make sure that every provider in every corner of America and the world, pricing obviously is lower globally, will be able to provide the care that they're called to provide when they provide it. And there was a slide here that I'll show you in a second, which is important for us from a marketing perspective. The woman here, the icon here, that's who we call Eva. Just like the product's called Eva, that's Eva. And Eva is who we engage with. Eva is the healthcare worker, the nurse, the midwife, the technician, that woman that serves day and night to serve the majority of humanity. And we seek to work with her. So from a basic service perspective, our goal is to provide that person with the tools she needs, and we'll work with her healthcare system, with her hospital network, to give her the tools she needs to provide care to her patients. Pleasure. So I'll wrap up on a very basic request from all of you. So when I was given the opportunity to come here, and thank you, Alana, again for making it possible, the thing that kept on going through my mind was how, to use a lack of a better term, how pregnant with potential this organization, Google, and companies like it are for impacting the very fundamentals of healthcare. Lessons that we have learned over the past decade in how to identify individuals, support those individuals through choices, ensure that they get to the right information at the right time with the right people, are lessons that are immediately applicable to every person on the planet. And MobileODT can only do its part in it, and hopefully will continue to strengthen the way that providers provide healthcare. Organizations such as yours and others in your peer group have so much opportunity to be able to fundamentally affect the human condition on whether a person lives another year or does not. And so I hope that you could use your superpowers, whether it be from marketing to business to engineering, to ensure that no person, no woman, no child, no father, no man dies of an easily preventable disease again. Thank you very much.